everyone. Thank you for tuning into our podcast about influenza. As we're getting into the influenza season, we thought this would be a very relevant topic to discuss. Joining me today are Dr. Faria Khan, Dr. Patel, and Dr. Alix Schnibben. Dr. Khan, can you please share something about you, what you do, and what's your role with NGPG?
Sure. I'm an allergy specialist, allergy immunology. I've been with NGPG for about 5 years.
And Dr. Patel?
Yeah, sure. My name is Dr. Miral Patel. I work in urgent care, family medicine, and I've been working with NGPG for about 3 years.
Yeah. Alix Schnibben. I'm the Director of Clinical Quality and Ambulatory Pharmacy Services for the Physicians Group, and I've been here for 6 years now.
Great. Thank you so much for joining today. As we all know, flu or influenza is a respiratory viral infection, and usually we start seeing the cases increase kind of getting into the fall and winter. Usually peaks in February, but sometimes like last year we see the peak early on. And it's very important that as we're getting into the flu season, we kind of understand how these patients present and also how to treat and what's the best way to prevent severe influenza infections. And Dr. Patel, I'll open up with a question to you. You work in urgent care. Mm-hmm. So as we're getting into the fall and winter and you start seeing patients coming in with respiratory infection, how do you approach that?
Yeah, sure. So we see that quite a bit. And so as we get into the fall season, typically for flu symptoms, we tend to see things like cough, chest congestion, fevers, body aches, joint pains, things like that. Typically people will wake up and have sudden onset of symptoms versus like a gradual progression. So that's something that we look for. And then as far as when we see those symptoms presenting, we do have testing available in our urgent care that can look at to see if we're dealing with flu or even COVID. RSV, those are viruses that do kind of present similarly. So we do have that capability to do PCR testing on site to see if and even what type of flu we're dealing with, either it's type A or B.
So, you mentioned about the PCR-based test. I think we hear a lot about rapid flu test. I think even the PCR test that you have in the urgent care is rapid.
Correct, like 45 minutes.
Yes. So, and it's a more reliable test because it detects kind of the nuclear material of the virus. But we don't do any of the antigen tests.
Correct. Yeah. No, we do not. No, we only do the PCR testing.
And that's more reliable. I think with antigen tests, I think the concern is that they could be false positives and also false negatives. So, and this test, as you mentioned, includes all the 3 different viruses and helps distinguish the strain of the flu infection as well. So Dr. Patel, when you see a patient who tests positive for flu, do you offer treatment with antivirals like Tamiflu to all of them, or how do you decide?
Yeah, so I think the general population that we tend to see has been aware of Tamiflu at this point because it's been on the market for a while and antivirals, so they are aware of it, and sometimes patients do ask for it. But usually the patient population that I will typically offer are the high-risk patients, the elderly patients, the ones that have severe comorbidities. Those ones will definitely be like, hey, this might benefit you a little bit more, prevent further complications, possibly like pneumonia and things like that. But I would say in true reality, I think it is offered to all patients at this stage because it's just so commonly known now.
Yes. And the other question, I think, to the panel is, there are other antivirals also available. And sometimes, like one of the questions I received last year was, patient has allergy to Tamiflu. What do we do? And Dr. Khan, because there's some other antiviral options also available, and is there a cross-reactivity if they're allergic to Tamiflu with other antivirals? Or what do we do in those high-risk patients that would benefit from an antiviral but they have an allergy?
That's a great question. So we actually don't have a lot of great data on cross-reactivity between a lot of the anti-flu agents. So if they report an allergy, and I'll preface this by saying not every reaction is an allergic reaction, so you really have to be careful about giving them that label. But it's kind of a quick process. They're sick. You have to do something, and you don't have time to test whether it's true or not. So you can probably, we kind of come to the consensus that you can use something else because we don't know of any strong cross-reactivity, but we don't have a whole lot of data either. So the final recommendation is, yes, you can try something else and see.
Great, thank you. Do you strictly follow the 48-hour rule when you're prescribing Tamiflu to someone?
Yes, for the most part, yes. Yeah, unless there's been maybe I might go on to day 3, but I think the best efficacy is in the first 48 hours.
Yeah, I think that's kind of where, especially I practice more on the hospital side. And I think there's just some select population, maybe different from what you're seeing in the urgent care, where they maybe benefit for Tamiflu even beyond the 48 hours. And Alix, you want to add anything about that?
I think it's case-by-case basis. So when you're in the hospitalized patients, it's much different. They're already in the hospital. Let's not get things worse. Let's try to give them everything we possibly can to help them feel better and prevent a secondary bacterial infection from their previous symptoms related to influenza. But on the ambulatory side, you have to take into account pregnant women. I think they're an exception to the rule because they can progress pretty quickly. We could have a poor outcome if we don't offer them everything we have.
Yeah.
And then you have to think about, like you said, those people that are progressing quickly with chronic conditions would be that other aspect. So if you have a layer of elderly, multiple chronic conditions, went from 0 to 100 real quick, those might be the people outside of the 48 hours that we would dig a little deeper in. I think the CDC has allowed that expansion of the label to make sure we don't have people come to the hospital. So I think, as Dr. Patel said, it's a case-by-case basis. But you've got those people that your medical spidey senses, as I say, tell you this is one I need to offer it past that 48-hour window.
I think that's kind of where the art of the medicine comes in. Of course, even from the best practice guidance, for most patients, it's important that we start as soon as possible. There may be some exceptions, especially those high risk of hospitalization, those with low immunity, or pregnant patients, or those who are already hospitalized, or those with the flu, pneumonia, not necessarily maybe just the upper respiratory infection. Another question that often comes up, what's the role of antibiotics, not antivirals, in patients with flu?
I would say, well, we know if it's flu, it's a viral infection, so it's always best to start off with the antiviral. I think the antibiotics would only come into play if there is a serious complication, such as a pneumonia, and you can actually see that, okay, is this consolidation or infiltrates? You can actually differentiate between what type of pneumonia you are dealing with. And then I think that comes in maybe probably like a week or 2 after the primary infection's done. And again, we're probably going to see that in more complex patients, pregnant patients, elderly patients, with comorbidities, things like that. So initially, no, I don't think that's a good practice to start antibiotics.
Thank you. I think that's very important because Z-Pak does not help with flu. I know that's a favorite antibiotic, and it's really the antiviral start as soon as possible. And as you mentioned, if they have pneumonia, that's when, again, looking for possible secondary bacterial infection, there may be some benefit, or there is some benefit there to add an antibiotic to the antiviral. When it comes to prevention for flu, of course, from an infection control standpoint, once someone has symptoms, I think the most important thing is hand hygiene, cough etiquette. Flu is spread by droplets or touching fomites that may have this infected virus, respiratory droplets with this infected virus on them. So very important to wear a mask if around others, and following really good hand hygiene and cough etiquette. And usually if they're in the hospital, we isolate them for minimum 7 days. But when it really comes to prevention of the infection or the severe form of infection, our most important tool is vaccine. And I think I'm going to go let's start with Alix, go to each of the members in the panel, really. If you, let's start off with what are the options for vaccination for flu that are available?
There's a plethora of options. I like to tell my pharmacy students that are on rotation with me, it is a disservice to your patient if you're not aware of what's on the market, because a lot of them are 18 years old and older. They're not for the pediatric populations. You have to be very careful because our pediatric population is very at risk. So there's multiple vaccine technologies that are available. So for your elderly populations, those 65 years and older, you have multiple options. One we most know is that high dose, which has got 4 times the antigen in it to allow that patient to build immunity over time, because it takes a little bit longer when we're older. We know that our risk of infection goes up and our immunity goes down, our ability to build immune response go down. So that's why we want to use those technologies that allow a little bit more time. So you've got your high dose, you've got your adjuvanted vaccines such as Flublok. So that's for 50 and up. Is its claim to fame, and gives them a little bit more time for immunity because of a side chain. But then you have your standard vaccines, your virus vector vaccines, subunits that are available that provide a great response too for those patients that are 6 months and up, but may not need as much available. Thought it was very interesting. ACIP last year allowed those that are immunocompromised, 18 and up, to have access to the high dose, giving that population that's at a great risk too, not just your elderly population, that access. So I think there's been a lot done in the last several years to expand the use of flu vaccines, resolving a lot of barriers, making the best one available on the market so that providers don't have to make that decision knowing that this patient really needs something better, but we didn't have recommendation for ACIP, so now we do. Then we've got one that's not made in, mammalian eggs, chicken eggs, that's available. People have an egg allergy, but we all know that was disproven 2 years ago. We'll let Dr. Khan expand on that. But, we have the availability for full access to vaccinations for patients whether they have an egg allergy or not. So the world is our oyster now. We've got lots of availability. You just have to be aware of the age in which it's approved, not necessarily the technology, but what age was it approved for.
It's very important. And Dr. Patel, you work in an urgent care setting. So patients are coming in there with some acute symptomatology, so maybe infections. So the place to get the vaccine would be the primary care offices. Or do you even carry vaccines at the...
We don't at the urgent care, but most of the primary care offices do have them. Pediatric offices will have them.
What months do you start seeing the flu cases? And the reason I'm asking this question is I hear this often. Let me wait till January or December to get the flu vaccine. I don't want to get it in October or September.
Yes.
So when do you start seeing patients coming in with flu?
So strangely, and this might just be a coincidence, but I've seen at least 1 or 2 flu cases a month, even over the summer months.
Yes.
And I think as people are traveling and all of that. So it's not like it's completely gone away, right? Yeah. And so that's there. But usually around, I would say when schools start up, we start seeing a big spike because, everyone's traveled. They're getting into close counters and, there's not much hygiene or hand hygiene going on. Yeah. So usually September time is when we start seeing it. Yeah. I think the biggest peak, like last year, happened actually in around October, November time, which was a little bit of a surprise. Yes. But so I would say, when patients do come in and they ask about it, we usually tell them to start looking for the vaccine maybe in August. Yes. So by the time it starts showing up, your body's ready to fight it.
I think that's very important. And Dr. Khan, from your subject matter expertise with immunology, because the concern is that, the immunity will wean off by the time we get into the winter. What do you say or add?
No. It will continue to protect you. It's funny that you said what you said, Dr. Patel. Last summer, I saw 2 cases of the flu in the allergy clinic, and I thought, this is crazy. But it is always prevalent. And just to... I don't know if you have this question coming up. I was going to mention egg.
Yes, please.
Okay. So as you said, Alix, so that is unfortunately still seen in a lot of offices, a lot of forms. Do you have an egg allergy? And just to give a little historic perspective about that, in about 2011, so we're talking about almost 15 years ago, we started accumulating more and more data for people who are egg allergic, even severe life-threatening anaphylactic egg reaction. They were taking the flu shot without any problem. And as we started kind of looking at all the data, we realized that this is really not a concern. It's more of a theoretical concern rather than a real concern, real world concern. And so the theory now is there's just not enough egg protein in the flu vaccines to promote allergic reaction. So that the data started coming in again, 2011. it became an official recommendation 2016, 2017. So now we're talking about 10 years ago. So that is just not a concern. So we don't have to ask that. It doesn't have to be on any form, although I still see it, which is very frustrating. But it's not a thing, as they say.
And to kind of add more to that, because I see sometimes patients asking, I have an egg allergy, it's really severe, anaphylaxis, but I want this special type of flu vaccine. And is that even needed, or they can get any vaccine?
They can get any vaccine, no matter how severely allergic they are. They did have Flublok. Is that the one that was egg-free? But you really don't need it anymore. When that was developed, it was still a concern because we didn't have the data. That was developed a long time ago. But we still, I think, say that if the person is just concerned to the point of they're going to have a panic attack about it, then, maybe we can offer that to them.
I think they're like the recombinant vaccine or, yeah, definitely. But they can get any of the options available.
Right.
Can they get the vaccine even if they have an allergy in any setting, or does it have to be like an inpatient setting or a hospital setting, or that's another question we get, that, okay, they have egg allergy, but can they get it at their primary care office or any other flu
They can get it anywhere. The risk is incredibly low.
The ability to respond to an allergic response.
Which is
they can get anywhere.
Which is no different from
any
anyone
vaccine.
who's, any vaccine.
And so the anaphylaxis to vaccine is about 1 in a million, literally very, very rare. And we don't think it's from egg for the flu vaccine. It's probably from some other component for the few very rare people that do have a response. It's probably some other component within the vaccine, more of an excipient type of vehicle, molecule or compound or substance in the vaccine. But the interesting thing about testing from an allergy perspective is we do offer flu testing for allergy to the flu vaccine. However, there's a but. There's not a whole lot of definitive data on the reliability of that test. So in practice, in real allergy practice, we used to do it a lot more often than we do now. We hardly do it anymore because, again, what are we doing? There's not really good data. And then the other thing is, if you wanted to do something like a graded challenge, which is a kind of test / administration, we don't have definitive data on the safety of that. So we've gotten to the point now, latest recommendation is it's a 1 in a million thing. Wherever you get it, and you can get it anywhere, just have the equipment available if in case you have that one rare patient who's going to have a reaction.
I think that's very, very helpful. When it comes to vaccine options, there's some who don't want to get any injectables, and I've heard they prefer the flu mist inhaled version. And is there any difference in terms of immunity or response that they develop following that flu mist versus the other vaccines, injectables, or the type of vaccine?
Absolutely. So flu mist is a live vaccine comparative to the other vaccines on the market. They are inactivated. So the live vaccine the last couple of years hasn't performed as well. Much less immunity response to it, less efficacy. We actually had a season where we wasn't approved to use because the previous season it had poor performance. But vaccination period, whether you get an injectable or the nasal inhalation, is better than nothing. So if a patient has an aversion to needles, we need to make sure we give them all the options that are available. We don't carry that within Northeast Georgia Physicians Group, but we do have the ability to refer to our partners in retail pharmacy to make sure our patients have access to it. It is a smaller window of people that can get it. 2 to 49 years of age are eligible for that one, and we caution against patients who have respiratory conditions such as asthma or COPD. Not because they're going to have any issues, they're not going to have a response, is we're putting something up your nose. If you have a really big cough reflex, we don't want to send you into a fit of where you need your inhalers. That's the precautionary. Now, I've seen people get it and be fine, but those patients have to bring their inhaler with them when they receive that, just in case if they are really not willing to receive an injectable, we still give them the option.
That's helpful. So is that so? It's not a contraindication, even if they have reactivated disease, they can still get it.
They can still get it, but we encourage them to get the not live attenuated if they do, because there is data that it does increase wheezing, especially in the pediatric population. So we're talking, 2 to 4 years old. There is some data that it does increase wheezing, and mechanistically maybe that's the issue. But we tell them, look, you have asthma, let's just get the inactivated vaccine because we have all these other options to do that.
Something else we hear often is, I got the vaccine and I got flu. Do you hear that?
All the time.
So how do you approach that?
And then they're like, well, I'm never getting this again. Oh, that's that is a difficult conversation.
Yes.
Because I think patients need to understand how. I think a lot of patients don't understand how vaccines work and how your body may respond to it. And so it takes a little bit of time to explain that, you're putting, especially depending on what kind of a vaccine it is too, like if it's a live vaccine, you might have a stronger response to it. And yes, you may feel a little bit ill, but that's not, you don't have the flu. It is your body building that immunity against it, right? We see that all the time. And, I do my best to encourage patients that this is a normal response. It's okay. And, that shouldn't discourage you from getting the flu next time, flu vaccine next time. But, this is your body literally building immunity against it when you really are facing the actual virus, right? So it takes a little bit of education for the patients. And most patients don't get that education even when they are getting the vaccine. Right.
Yes.
It's also timing of the vaccine. It takes 2 weeks for it to get in there and do its work. So you are vulnerable within that first 2 weeks for receiving the vaccination to have experienced the flu. So it's not that the flu vaccine didn't work; it didn't have time to work. So I think that's something from vaccinators who give it, whether it's in a retail pharmacy setting or a provider's office, that we have the opportunity to explain that for 2 weeks you are vulnerable to the flu and you could still get it. And like you said, it's depending on what vaccines created for the year. We've gone from a quadrivalent to a trivalent our last flu season, and there's only certain serotypes in there. So there could be something else circulating. And they've picked up that strain of the flu and not the one that was in the vaccine. So I think it's a lot more of, at the time of vaccination, spending a little bit more time to explain, you got it, great, this is what's commonly circulating, but you still are at risk, but it'll lessen the symptoms if you get it, but overall we've decreased your risk. So I think it's more of that patient education piece to really understand you're not going to get the flu from the flu vaccine.
Right.
And then if that does happen, people like Dr. Patel taking the opportunity to re-educate that let's set that fact, flu shot's still good. Let's explain what happened. So hopefully we can continue to have their trust to receive it the next flu season.
I think that's so important because even with the COVID vaccine, I think the most important thing that's also sometimes forgotten is that even when they get the flu, because if it's a different strain that's not covered by the vaccine, there may still be some cross protection. And the vaccine still protects the severe form of the disease, the mortality, morbidity, the hospitalization. So I think that's very important that they're aware of that as well. Because, depending on year to year, there's always that, again, those who may not have a lot of medical knowledge, when they read in the news that, the vaccine does not cover the flu strains.
Right.
This year, I think there's still some cross protection. That's what we see, that if you get the vaccine, it still protects the severe form of the flu. One other question we get is those with history of Guillain-Barré, can they get the flu vaccine?
I mean, I think it's patient specific. There are some neurological conditions in which we've spoken to our neurologists that they identify a patient should not get. You've had it before, you have a risk, but it's by patient case. I've seen providers. How long has it been since you've had it? Was it a recent thing? So I think it's each individual patient I've seen, because I've still seen patients get the flu vaccination, but these have been those really high risk elderly patient, we know, a COPD, CHF that goes to the hospital a lot. They're weighing that risk versus benefit for the patient. So it's more patient specific more than ever that I have seen for providers. But I think it's awareness of maybe asking the neurologist sometimes, should a patient still get it or not? It plays into the factors of everything.
I think very important that we make every effort to protect our most vulnerable during the flu season. And when I was researching for the podcast, some of the data that I noted is that the risk of Guillain-Barré from the flu infection is higher than the risk of Guillain-Barré from the vaccination. Maybe documented 1 or 2 cases from million doses given, whether it was directly related to the vaccine or not. So I think that's something that when we think of flu, we kind of associate that with more upper respiratory infection. What we see on the hospital side are patients with flu pneumonia, respiratory failure. Sometimes it can present with myocarditis, even CNS infection and Guillain-Barré. So flu can cause a lot of these complications. And if patients develop secondary bacterial infections, with Staph aureus being the most common, that can also cause further complications and increase the risk of mortality and morbidity. When it comes to flu strains, a question we get, Alix, is, okay, which vaccine? We hear about quadrivalent, trivalent. What is the recommended vaccine I should get? And or somebody else is making the decision for me when I go to the clinic. Do they carry only a certain type of vaccines?
Yeah, absolutely. A great question. So, each year they do evaluate what occurred in previous flu seasons and other flu seasons across the world, not just ours. And we, rely on other hemispheres to kind of tell us what was circulating for their flu season for us to know what to put in our vaccination. So, we've always been quadrivalent for years, at least since I've been practicing, which is not as long as everybody here. I'm great company right now. So it's always been quadrivalent. But when we dug a little deeper into the data, this past year was our first trivalent because one of the circulating strands really wasn't circulating as much. They didn't see any benefit. We don't want to have any risk associated with the vaccination. So the decision was to make it trivalent. It was still, everything I've seen, been as effective as it's been in each year. Wasn't any decrease in efficacy of what's come out so far. And so I think it's decided on us by, ACIP is involved, CDC is involved. They look at what's circulating, and it's always decided. And then it becomes a universal thing of what's in the vaccination, of what serotypes are in there, and then everything is trivalent. So there isn't a quadrivalent and a trivalent. With the exception, high dose did take a while to become quadrivalent. And the season before we went trivalent was its first year as quadrivalent. And then we go to trivalent. So I think it's, making sure that we maintain education. I think that's one of the things here. When we heard a rumor that it was going to be trivalent, we started educating our clinical support staff, our front office staff, our providers. Hey, there's going to be a big change possible. As soon as we're aware of what it is, we'll let you know. That way we could start educating the vaccinators so they would be able to clearly explain why there was a change. But it is decided for us. Every vaccine carries the same. It's just what type do you want to receive based off age or other, if you have immunocompromised, how old you are, really decides what's available for you to choose. And it's not chosen for you. I get that question. But we have to pick what's in our organization. So we do carry one standard dose trivalent that can do 6 months and up, and then we do choose one that's available for our immunocompromised and our elderly population. And historically, we've done high dose within our organization.
What if someone goes to a clinic that doesn't have the high dose, but they're above 65 years of age? Can they just get the regular dose vaccine? Why the high dose?
Yeah, we don't want to miss our opportunity to vaccinate. Yes, if we can get the high dose quickly for them and then come back tomorrow and get it, or we can call the pharmacy down the street and get the access. But if we're in a shortage, we want to vaccinate with whatever is available that's approved for them to receive. We don't want to delay that vaccination. I usually say if you can find it within a week, let's do it. If we can't get it within a week, we need to vaccinate what's available to us. Any vaccination is better than no vaccination, as Dr. Khan says.
It's very, very important. And Dr. Khan, what would be absolute contraindications to get the flu vaccine?
There really aren't a whole lot. I would say just for the live attenuated, going back to that a little bit, respiratory diseases, and especially pediatric, you have to be really careful about that. And low immunity, immune deficiency. So for the live attenuated, we absolutely don't recommend that at all. But the inactivated are fine, all the different things, but not any absolute contraindications.
So if you mentioned about the allergy testing and graded challenges, and let's say someone who doesn't have egg allergy but has had a reaction to flu vaccine, and they refer to your clinic, and the reaction is severe. Would that be the right setting to do the allergy testing and graded challenge, or they just go to something different?
We could do it, but again, there's so little definitive data. But we could do it. We've had it's very case by case, and it's rare, which is a good thing.
Yes,
but we have had a very few handful of patients in the last 5 years, maybe one or two, that we did give. She had a history. We couldn't really determine whether it was truly anaphylaxis or not, but she was incredibly concerned. And so we kind of gave piecemeal dosing, which was really shooting from the hip, so to say. There wasn't really any evidence. It was just kind of catering it to her situation and her comfort level. And we were able to give the whole dose, but it was just kind of spread within a few days. And that there's no data, there's no evidence. It's just that that's what we did.
That's what you did.
So,
So if they have true anaphylaxis or severe allergy to flu vaccine, then that would be an absolute, just good to...
It could, but then it makes me wonder if maybe it was that particular one. And like Alix was saying, there's so many other choices. So if we could somehow pinpoint what is it, which one did you actually get, and maybe we can go with another one, because again, we think that true anaphylaxis happens not from the actual flu part or the egg part, but some excipient or vehicle, which are other compounds in the vaccine that are kind of containing the live treatment.
I think that's kind of very important, because if truly there was a reaction, just getting into that full history, seeing what alternatives, maybe coming and seeing you in your office, that will help to make sure that it's not labeled as an allergy and they don't get vaccine moving forward. Same thing about feeling like they got the flu from the vaccine. But especially inactivated vaccines, they don't even contain the flu virus, so they cannot cause flu. And it may be just your body building that immunity. Dr. Patel, when you see a patient with flu, what are the instructions given to them so they just don't go about business as usual and spread it to others?
Of course, So, I mean, it is a respiratory virus. So a lot of the spread does happen due to droplets. And so one of the things I'll definitely say is put a mask on, especially if you're going to be around other people, and especially close encounters. So that's number one. Number two, wash your hands frequently, right? And even if you are, like, let's say blowing your nose or whatever, just wash your hands frequently. I think between those two things, I think you're going to have less spread. And then again, like, we don't have quarantine guidelines like we did with COVID in the beginning and stuff. But if you do have a fever, you are having a lot of secretions, cough and all that, then just stay home from work or school. And until you're actually getting better, you're seeing, your symptoms improving, fevers are going away, then there's less spread.
No, thank you. I think that's very helpful. Let's say someone gets flu in September, October, and they still have not got the vaccine. Do they still need to get the vaccine after they've already had the flu?
I would recommend it, yes, they should, because again, it covers more strains, and you may have gotten strain A, and you might have better coverage for strain B or other ones out there, right? So I would still recommend it.
I think that's still very important, given because of these different strains. They may have had infection from one strain, there may be other strains circulating. So I think it's still important they get the vaccination.
I wanted to just add one thing, and this might just be that, every year when they make the flu vaccine, the substances, whatever the carriers are, it may change, right? And so, correct me if I'm wrong, but like if you have an allergic reaction to it this year, it's not guaranteed you're going to have an allergic reaction to it next year, because that vehicle might change based on manufacturing and all of that.
Absolutely.
So I just wanted to add that.
And that's very important. And there are different types of vaccines also, which contain different adjuvants and even how they're produced. Like the recombinant one is kind of mammalian cells, culture of the mammalian cells. And so I think it's very important that we get into those details about what vaccine did they get when they had that reaction. Was it even a true reaction? And if so, what are the other options available? Because we do see when we see patients in the hospital where they're coming in with the complications from the flu infection, and we could see this could have been preventable. I mean, even if they had the infection, that would not have led to hospitalization or the Staph aureus infection in the lungs. That's kind of where we feel like, okay, we could have done something different. I think this is great discussion. Thank you. And we touched on so many different topics, from symptoms to prevention, vaccinations. And I really appreciate all of you joining me today. Thank you.
Thanks for having me.
Thank you.